Hi, everyone. Welcome to the Love and Larry podcast. My name is Rebecca Love. Again, Marion, so great to see you. We're so excited to host this event with you guys in advance of one of the largest strikes in history for nurses and others across the state of Massachusetts. Today, we have two guests on us joining us for MGB Home Care. We're going to talk about the strike that kicks off on July 8th for 7 days in the state of Massachusetts. We have Shannon Vieira, who is a nurse, and Kara Wilson, an OT, and the entire scope of the strike that is imagining at this point is hitting nurses, PT, OTs, social workers, and dietitians who have decided to go on strike in one of the largest movements in history in the state of Massachusetts. Shannon, Kara, thank you for being with us. Marion, where do you want to start this discussion?
Well, thank you both for being willing to come on the podcast and talk about the strike and the reasons behind it. I think let's start there. For those who don't understand what led up to this decision to strike, because I'm sure it wasn't an easy one, and why you all are striking and have decided to strike, start with explaining the reasons why.
Thanks so much for having us, guys. And before we move on too far, I just want to add that we also have speech language pathologists in our union. I don't want to leave them out. They're really important to what we do, especially in home care. But if you want to talk about why we're here, we kind of need to start at the beginning. About 2.5 years ago now, management changed all of our working conditions. We operate on a point system in home care, which if you haven't done home care, that is a very vague idea. It essentially assigns a weight or a time period to each visit. So a start of care or admission is very time sensitive and takes a long time. So that would be a 2-point visit. And then a revisit, the patient is known to you, you go in and out fairly quickly, under an hour, that would be 1 point. They took away the point system. They told us every visit is the same. And then they made nursing salary, took away our overtime, and also increased our health insurance contributions. So life as we knew it went from bad to worse. And
Can I ask,
yeah.
did they give reasons for that?
Kara, do you remember? I don't remember reasons. I just remember them saying, this is what we're doing.
We had a new CNO that had taken over, and I think the idea was to create efficiency, create more money for the company. So we really ended up working significantly harder, probably 20-25% harder in terms of productivity levels than we had been. And we had already been struggling before that even happened. So it was kind of the thing that brought us all together to make us realize we needed to act and stand up for ourselves and try to get a better work-life balance, because we were all really struggling with that.
I would add to that prior to them changing everything, they had made us start clocking in and out in UKG. And I think that moment they realized, oh, wow, these people work way longer than we really expected, and now we have to pay them all this extra money, so let's make them salary so that we don't have to pay overtime anymore.
And Shannon, speaking to that, and Kara speaking to that, what would you say would your average day look like? How many hours were you spending on the clock when you were clocking in on an hour system by UKG on average?
It definitely depended on the day. You know, that's the thing with home care, is that it's fluid. It can start out really good and end in disaster, or you can expect a really bad day and end up having a really good one. I would say, an 8-hour day for a lot of people is easily actually a 10-hour day.
Kara, are you finding the same side on the OT side?
I am. I work 32 hours a week, well, technically 32, but I really work probably close to 40, 39, 40 hours every week to get the job done. And I think that's, what we were all struggling with, is that we wanted to do a good job. We want to get the job done. We want to get the star ratings that the company's looking for, but we need time to do the job.
Which makes perfect sense. And I think the question that we have for all of you guys, for those that don't understand home care, I mean, this is a pretty extreme example of an entire organization going on strike. Are you guys the first in the country to actually strike in this model that you're aware of, specifically in the home care space?
I know that in the Boston VNA physical therapy union did strike a couple of years ago. So I don't think that we're the first. We might be one of the bigger ones, but there have been strikes before.
Well, this is very helpful because I think people don't know that this even kind of division was. Now, we know that you guys are running parallel to a strike that is actually going to be occurring in the hospital by all bedside nurses in the hospital around that time. Now, Shannon, I know that you guys are in talks with them. You're not in the hospital, but can you give us a little bit of an oversight of what's happening also at the same time? Because I think just the scale of this strike and how far it's reaching from both inpatient all the way to home care is what is so unusual about this. Can you speak a little bit to the knowledge that you have on the nursing strike that's taking place for inpatient nurses at Brigham as well.
Yeah, for sure. So, Brigham has a long-standing union that's been very powerful over the years, and they walked in for negotiations, having really settled a contract very recently, but late to start their next negotiations. And they said, "Let's get this done fast. We're not going to ask for much. Like, let's do it." And management has held to offering a 0% wage increase and increasing health insurance contributions. So, effectively taking money off of the nurses' plates. And they are arguing that they already have a 5% wage increase every year, which is built into their contract as it is between every step. The more experience you have as a nurse, the more money you make. So they have a 5% increase every year, but that's not actually super helpful with the cost of living in the city.
Thank you, Shannon. And what day is that occurring? Are the nurses going on strike from the inpatient?
Yes, so they're striking the same day as us on July 8th, and then the hospital has decided that they're going to lock them out for an additional 4 days. So they'll be out of work for 5 days.
Can you talk a little bit about that? So the nurses are doing a 1-day strike, but the hospital's locking them out for an additional 4 days. What's that about?
From my understanding, that is because they can only hire scabs in contract windows. So it has to be 3 days or 5 days or 7 days, whatever the case is. So they're choosing to hire them for the 5 days as opposed to just the 3 days.
And how does that affect the nurses that are on that went out for 1 day? What does that mean for them, Shannon, when they're locked out for an additional 4 days?
So they won't be able to care for their patients. They won't be paid for that time. As when you're on strike, you don't get paid. And, it's really going to harm the entire system. You will be out at the same time. So our patients aren't going to be getting care. They won't be able to discharge patients to home care to make room. It's going to be kind of ugly.
This just seems like a compounding effect.
Well,
Marion,
it
go
all,
ahead.
no, I mean, compounding, but seems like a tactic on their end, right? Like keeping nurses out for an additional unpaid 4 days with, I don't know, the hope that maybe that will dissuade them from striking. I don't know what the motivation is behind it, but that's how, as an outsider, I sort of see it.
I see it that way.
Yeah, why would you not want your nurses to be paid?
Yeah, it's causing an inordinate amount of pain and hurt to those nurses who have decided to go out on 1 day to suddenly be affected by a total of 5, which we understand is absolutely, to your point, Marion, appears very much a tactic or a strong arm tactic to basically create a warning shot across the bow that, is this a question of actual good faith negotiations, or are these going to be strong arm negotiations, which is a very interesting time in this world of dealing with unions in general. And you guys actually, this is highly unusual. Massachusetts is one of the few states left in the United States that actually does have union representation at this level. You guys are often a voice. And why Marion and I wanted to have you both on this podcast, and thank you for being here, is we know from our own personal conversations that a lot of the nursing community across the United States is watching this strike very, very carefully. And they're paying attention to it in a way that we have not noted them paying attention to strikes in other parts of the United States, such as California, or even those strikes that occurred in New York. And I'm curious as to why we're sort of puzzled by the intense focus that this strike is bringing. But also, we would love you guys just to sort of talk a little bit. There were some of these things that you talked about with proficiency standards and efficiencies that have been brought forward into your workspaces that is, I think, rather unusual. And there are sort of some studies. So Shannon, can we talk a little bit, and Kara, about your caseloads and what does that mean? Because I think for people who aren't paying attention, they're not sure what a caseload is and what that means to actual practice, because they're thinking to themselves, you guys see one patient at a time, but actually you guys are carrying significantly high numbers of panels of patients that are driving direct revenue for the organization that you're carrying. So Shannon, Kara, why don't you go first? Tell us a little bit on the OT side, and then Shannon, you jump in.
Yeah, so as an OT, I work, like I said, 32 hours. I have had upwards of 34 patients on a caseload working 32 hours, which, as you can imagine, as nurses, can be quite overwhelming. In home care, you're seeing every patient for at least 45 minutes to an hour, and working 32 hours trying to see 34 patients is really impossible. So I need to rely a little bit on an OT assistant to help me carry some of those patients. But when you're responsible for that many people and you're wanting to deliver really good care, it's really hard to keep track of that many people working 32 hours. And it just becomes more of a safety. I try to see 4 to 5 patients a day, working 6.5 hours a day. But like I said, I'm usually working 8.5 hours every day. So there's just so much responsibility that we as home care clinicians carry because we work by ourselves in the houses. So when you walk in, you're not just I'm not just the OT. I could be the nurse that day. I could be, the physical therapist that day or the speech therapist or, depending on what's going on in the situation. So you never really know. Your visits end up taking longer than they normally would when things go wrong or things are happening.
I think home care is really special. It's a really important area of healthcare that is often overlooked, misunderstood, discarded. But we see patients in their own environments, which gives us so much information. You can tell right off the bat if a patient is food insecure, if they need, help with social work to get them food services. You can see immediately, that there's no caregiver there to help them. And so the doctors are discharging them home from the hospital thinking they have all this support that's truly not there. So we do a lot of education in home care, which takes a lot of time, right? And caring for 30 patients on your caseload, there's a lot more that goes into it than just the face-to-face time. You're calling doctors' offices. Sometimes you're calling pharmacies trying to track down meds or changes. You're ordering supplies for the wound care. You're collaborating with the caregivers. There's so much more than just the FaceTime with the patient.
And to add on to that, even for therapy, PT and OT, there's a lot of equipment need in the community. And then when you've got all the social issues on top of that, it can make it really hard to figure out how you're going to find the appropriate equipment for patients to be able to transfer safely and not hurt themselves, not have falls, not go back to the hospital. Because we want to prevent rehospitalization rates from increasing. And we just want to keep people safe in their homes.
So based on all of that, what are you hoping to see come out of this strike?
We're looking for productivity metrics. So like we talked about before with the point system, we need that back so that we can have some balance in our workday. We're also looking for caseload limits so that they can't just keep admitting patients to your caseload when you've already got 30 patients. I was talking to one of my colleagues recently who had 50 patients on her caseload. How do you manage safely 50 patients when you only work 40 hours a week? Like, it's just not feasible.
Right. And I think
And isn't there studies, Shannon? Shannon, what is the studies of a safe caseload historically? What is the maximum number that a patient should, or a nurse should carry, and an OT should carry as a safe way based on actually optimizing for home care?
So what I had seen a while ago now, but it was 25 patients on a caseload for best outcomes, and ideally 18.
So you're carrying double to potentially almost triple in some of these scenarios. That based on best outcomes at this point in time is really what the workforce is being pushed to do. Where before, when you had proficiency metrics, you could actually qualify and quantify based on data, making the best decisions not only for your delivery of care, but for the safety of patients. All with those things being removed now makes that invisible and not able to actually effectively communicate and respond to the data that's being presented, which I think makes very good sense. And data-driven decisions is absolutely factually the most important, best way to run healthcare systems, and one that I would completely agree with is a baseline of support that absolutely must be coming back for B&W to measure this home care effectively. Marion, you were going to say something. I interrupted.
No, it's okay. I was just going to say, you all are striking for the safety of your patients, right? That fundamentally, you're just trying to make it safer for you as healthcare providers to safely treat your home care patients. And for that, I applaud you. And I'm sorry that you even have to do that. And I think we all know that healthcare is an industry, and we really, really want to see healthcare putting patients before profits. And I am assuming that is the primary reason you all are doing this.
We know, for example, that patients that are in hospital days are sicker than they've ever been. They're being discharged faster at rates than they ever were before. We used to keep patients in the hospital until they could walk and talk and care for themselves. We know that that is no longer the faction. We are discharging patients who should still be in the hospitals at home, and you guys are the ones keeping them safe and trying to prevent their hospital readmission, which actually that data you need necessarily to show the effectiveness of your interventions to predict those things that are actually keeping your STAR scores high, but more importantly, your reimbursement highs, because we know if those patients are discharged and within 30 days readmitted to a hospital, the hospital eats 100% of that increased expenses. So not only are you driving revenue for the hospital by actually taking these patients onto the loads, you're preventing one of the most impressive areas of hospital cost, which is 30-day readmissions. All of that, which you must need access to more data, not less, and why proficiency metrics and data should be shared equally across both the providers that are providing it as well as the executives who are driving it. And as Marion said, patients before profits is very interesting. We just saw something very interesting that the M&A actually published, which showed something like 14 of the top executives working across the hospital system are equivalent salaries are equated to, I believe, $35 million. Can you guys talk a little bit about the research and why the M&A went to look at these things and what was the point of bringing this information forward?
I think honestly, it's just to show the difference between what the people on the front lines who are working directly with the patients are making and how hard we're working, and how people at the top are raking in a lot of money. And there's a real big discrepancy there, and we need to like stop putting all of the work that has to be done on the clinicians who work on the front lines and not reward them and value them and respect them for the hard work that's being done. I mean, like we talked about earlier, you touched on the cost of living. And I know so many people who I work with who are struggling week to week to make payments on rent or mortgage because the salaries are just not keeping up with the cost of living rises. And it's a real issue. So we're just trying to show the discrepancy, I guess, to answer your question, with what we're making and how hard we're working and what people at the top are pulling in.
No, I mean, that is so important. I mean, last year, the system reported $2 billion in net gains. $2 billion with a B. So obviously the funds are there to pay you and Shannon, the wages you need and your colleagues to have a higher quality of living, and to show that the work you're doing is comparable to the pay that is required to provide that level of care. I think, health systems forget that nurses, OTs, speech therapy, etc., we're all professional, highly qualified, highly educated, skilled providers, and should absolutely be compensated as such.
Agreed.
Absolutely.
Yeah, I think it's important to note that Becker's hospital review said that MGB is the seventh wealthiest hospital system in the United States with, I think, $35.8 billion in assets.
It's true. I mean, the truth is, it is one of the top performing hospitals in the entire United States, arguably in the world. Therefore, the reason that they are those top performers is they depend on those who work for them to deliver the top level care, which is you guys on the front lines, which means top level hospitals depend on the organization and the employees that they have to be top level performers and to justify top level pay for the environments that they're living in. For those that are listening, you may not be aware, but Boston actually ranks 53% higher than the U.S. national average of cost of living in the United States. So although these numbers may sound exceptional based on other places that you're calling in, most nurses, most OTs, most PTs are squarely living very central, middle of the road, middle class lifestyles in a very cost competitive area that makes it difficult to maintain quality of life, not only for themselves, but for their families. With the dramatic increase of food and fuel and gas prices and everything that is occurring, nurses and OTs, PTs, respiratory therapists, dietitians, actual quality of living is actually showing to be decreasing for the first time in generations across the actual area. And these are why these nurses are striking, not because, and OTs and rests that are with them, not because they're worried that they themselves are personally being risked in all of this, but because the discrepancy between those at the top and those delivering the care have such discrepancy, and the quality of life, both for those patients in which they're serving and their own families, is now at risk. And I think we all feel this. I think the truth is that right now in America, more so than ever before, we are tired of being told that by those at the top that we should just be doing more with less at the bottom. Stop having avocado toast. Stop stopping and getting coffee. Go ahead and continue to do more with less, so that those at the top can rank in hundreds of millions of dollars in profits that are distributed, as we just saw, on average to $2.5 million salaries for the top 14 executives across that system, where the average of these nurses and OTs and PTs are making under $100,000 within their own scale. This to us is just the topic, I believe, of fairness that most Americans are resonating with today. Feeling as though the discrepancies of what is occurring in our systems are creating a system more between those that have and those that have not, when those that are middle class, working every single day, full-time jobs, putting in more and less, cannot make ends meet. And if you cannot make ends meet as a nurse in this country, as an OT in this country, God forbid you are any of those professions, how are you going to support a family if you can't make it as those professions? And this is a question of fairness in today's society, and one that I think is speaking at the strength of your strike. You're not striking because of money and wages. You're striking because the discrepancy of being able to live in this society is being unfair between the top and the bottom, and it is time that you guys have thrown up your hands to say the system needs to address it.
And just speaking to that, hearing you talk about that, it also raises the issue of retaining good clinicians, right? There's the retaining. and retention. And that's really important. We need to be offering salaries where people can live well. And just in terms of working, if someone working 40 hours should not be working 50 hours, because then your actual hourly rate goes down. So that's a whole other issue too.
Yeah, I mean, all of these things have compounding factors, right? So the Department of Education not classifying nursing as a professional degree now knocks out loans for a certain segment of the nursing population. Well, okay, now we're not giving nurses the loans they need to get and continue their education. We're also now not paying nurses a comparable living wage. Like, these things compound, and we already know that there's going to be a nursing shortage. We already know there is a huge problem with recruitment and retention. It is a compounding factor that boggles my mind that higher executive level folks at these institutions don't understand how all of this plays together. And it's why, again, I applaud what you all are doing, because you're bringing notice to this in a way that apparently only will be seen if you go on strike.
Yeah,
So as
I
we're
think
wrapping,
it's important. Oh, sorry, Rebecca. I was just going to say, I also think it's important to recognize that the board of directors that oversees Mass General Brigham is comprised almost all CEOs, bankers, venture capitalists. There's almost no medical professionals on that board. And the ones that are medical professionals are working in pharmaceuticals or private industry. They're not actually providing patient care to anybody.
Again, that just highlights the fact that healthcare is an industry
Mm-hmm.
it is a
and
business.
it's a business.
Really
And I
changed.
think, right, exactly, Kara.
And I don't think any of us disagree that it shouldn't be a business. I think the reality is you have to make money to provide good services. But if you are going to be the top ranking hospitals, you have to recognize that there is a level of fairness that you have to do, that we're all in this together. As humans, as hospital systems, as healthcare delivery systems, at the end of the day, we're caring for our communities. And if our career people that provide that care can't afford to live in those communities, can't afford to put their families now to put food on the table or save for college or do the things that need to do, that they used to be able to live very good quality of lives. We're just asking for a basic level of fairness. And I think if anybody is listening to this, the executives that exist out there who don't remember what it was like when you couldn't afford to pay for your child's college tuition without significant loans, or you couldn't afford to put gas in the car to do another trip to these months, there are people that we know in these circumstances whose dollars are running out before the end of every week. And what these nurses, OTs, PTs, respiratory therapists, dietitians are saying is that for fairness, we need to look at these as a system as a whole, and that there should be recognition that the work being done, make sure that we have data so that we can articulate that patients are safe, that we're carrying safe workloads, that wages are keeping up with the cost of living within these greater communities. And at the end of the day, for systems to win, we invest when we all win together. And to me, that is why we actually stand with you, Marion and I, and many other nurses and OTs, PTs, respiratory therapists are watching what you guys are doing, because the truth is, takes courage to stand against a system. And I've only ever seen nurses strike and others and healthcare professionals is when they have reached a point that they no longer can exist in a system that no longer values the ways that they need to operate to be safe, effective, and care for their patients. So Kara, Shannon, with that being said, one final statement from both of you guys, because we know you're about to head into one of the most grueling, stressful, exciting, and moments of change and opportunity with the week ahead of you. But Shannon, final last thought.
I think that Mass General Brigham is making a point to be difficult with us because they've seen such a massive wave of unionization across all of the system. And I think that they need to look at why. What have they done that has created that wave? Because it was them who caused it. They have created the need for the worker bees to work together and unionize to get some power back.
Thank you, Shannon. Kara?
So that was actually going to be my last thought too. But just to bring another thing up too, I think there's really an important part of this is also time away from work for good self-care, because if we can't have good self-care as clinicians, healthcare professionals, how can we be possibly able to take care of the people who really need us? And when people are working 50, 60 hours a week, we're not getting that self-care. And so that's my other thought. It's also about work-life balance and how important that is.
We recognize the differences in the shoulders on you guys. That 50 to 60 hours a week in front of a computer is very different when you're dealing with patients who are chronically, acutely, desperately ill, that rely on you not only for their physical and emotional, but also spiritual, social, and everything that's on their shoulders. Because at that moment, you are the people that are standing between often not only staying at home and hospitalization, but also between life and death in some of the most precarious moments of anybody. And as all of us as humans first, I would always hope that that patient and person taking care of me had that ability to stand there in good faith, knowing that they weren't being rushed out the door, that were actually to provide care for me and not exhausted and burdened because of the system that is failing them. So with that, you guys, Marion, final thought?
My final thought is history has shown that the people united will never be defeated. And Rebecca and I stand in solidarity with you and the rest of the nurses who are taking a big risk and putting everything on the line for their patients and each other to strike. So we wish you good luck, and we are here in support and solidarity. With that, we're going to close it out, and we will thank you both for being on, and we will see you at our next episode.
Thank you, guys.
Thank you so much, both of you.